So in my own practice, I nearly always continue bevacizumab beyond first-line progression. And the rationale for that is multifarious. There are several studies now that have demonstrated a proven clinical benefit, in fact, a small overall survival advantage in patients who continue bevacizumab beyond progression. We also have retrospective studies, in some cases of several thousand patients, which lead us to the same conclusion. In a patient especially who has a RAS mutation and who therefore is not a candidate for an anti-EGFR drug, their treatment options are more limited and indeed don't have a second antibody to turn to in a rational way. And because of their limitations of therapy, I believe in trying to get as much mileage out of every therapy as possible. And so all of those things, in my mind, justify the continuation of bevacizumab beyond first-line progression. So there are several studies which lead us, I believe, to the conclusion or the support for using bevacizumab beyond progression. There are, as I mentioned, is a large retrospective study which suggests that that's the case. It obviously has inherent biases in it. There are several randomized trials to which we can turn for some support as well. The first one would be the trial known as TML, or Treatment Through Multiple Lines, which showed approximately a 2-month overall survival advantage in patients who continued bevacizumab beyond progression compared to those patients who have not. Going back even farther, ECOG 3200, which was a trial technically of second-line therapy, although the patients had not previously been exposed to bevacizumab, did better when bevacizumab was included in that. And finally, the aflibercept registration trial, which was a phase 3 trial of the other anti-VEGF therapy known as aflibercept, also showed an approximately 2-month median survival time advantage for those patients who continued that, having received an anti-VEGF antibody in the first line. So one of the nice things about using bevacizumab for patients in the first line is that, as I like to tell them, in general, it has very few side effects, but has a number of significant risks. Now, luckily, those risks are infrequent events which don't happen to the majority of patients. In fact, the vast minority of patients experience a very significant side effect or toxicity with bevacizumab. Those things include both arterial and venous thrombotic events and other important toxicities. However, the majority of patients who take bevacizumab in first and second line will not experience dose-limiting toxicity in any way. And in fact, the contributions to their day-to-day subjective toxicities are relatively small. So I have come to be a very strong proponent of maintenance therapy, and I certainly use maintenance therapy extensively in my practice with patients with metastatic colorectal cancer. The rationale for this are several-fold, but include the fact that being on combination chemotherapy for long periods of time is quite taxing with respect to toxicity in patients. Number two, we have learned over the course of many years of treating patients that long holidays from therapy lead to a shorter progression-free survival and perhaps even to a shorter overall survival. And so patients in my practice in general do not take long holidays from therapy. They therefore have to continue therapy for long periods of time. And so the idea of modulating the intensity of therapy with more intensive therapy alternating with less intensive therapy is a very appealing one. Well, as I like to tell my patients, this is a marathon more than a sprint, or a chess game rather than a checkers game, and that what you do in the beginning of therapy is going to affect what happens in later lines of therapy. And especially if patients have significant wear and tear from chemotherapy over long periods of time, their ability to withstand that intensity of therapy becomes very difficult as their disease progresses and as they go on to second and third line therapies. So I try to pay very careful attention to toxicity management throughout the course of illness. I dose reduce liberally and often when patients seem to require it. And that helps, in my mind, to allow patients opportunities to take therapy further on.